Let's see if this will work for me. Okay, can everybody see just the slideshow presentation today?
Yes, that's perfect.
Great, thank you. And so I thought it's going to be a pretty short presentation. I want to give a little overview of what distress tolerance is. We have so many behavioral health providers. I think everyone is pretty well aware of this topic, so I won't go into too much detail. And then I thought I would describe 3 kind of quick strategies that could be used in your office to help patients calm down. And then I wanted to leave some time for us to talk about case examples, how to handle those really tough cases. I have a couple, and I know at least the sharp individuals here, I'm sure will have a couple of de-escalating tips to pass your way. Okay, so let's start with what is distress tolerance. So most of distress tolerance comes from dialectical behavior therapy. It's about being in the moment, tolerating and surviving crises, and kind of accepting life as it is today in the present moment. We are going to focus kind of on two subsets of distress tolerance skills. Just some distress tolerance skills are things to give patients to help them kind of self-soothe at home when you're not around. But these are more crisis survival skills. Actually, we're going to focus a little bit on grounding techniques, because I think those are the ones that are easiest for us to use in the moment in a session when a patient is in distress. So just to keep in mind, distress tolerance skills are short-term solutions to painful situations. They make that painful situation more tolerable so the person can refrain from impulsive actions that would just make the situation worse. The concern with distress tolerance skills is that they can be overused, and they shouldn't be a substitute for intensive individual or group therapy. They're just kind of helpful tools to have as a provider in your toolbox to pull out in a difficult session, or to help a patient get through a difficult situation. But think of them as kind of the Band-Aid, and we want to think of therapy more as healing the whole person. And one of the parts we're going to focus on today, like I said, is grounding. So these are techniques that are helping our patients come back to or remain in the present moment. I think of these have come up for me in therapy sessions where a patient has a lot of trauma history and they are dissociating in session based on what we're talking about. Grounding can help bring them back to that present moment. This could also be somebody having an anxiety attack, panic attack in the session, kind of helping bring them back to the present moment. And the 3 that I'd like to talk about today, the first one is kind of my go-to. My patients know that this is kind of my strategy in session for them to use. I call it the 3 things exercise. If anyone has a better name for it, I would love to hear your thoughts. And then we'll talk a little bit about square breathing and mindful attention. And we have Amanda and Lauren here who can talk about some of this with kids too. Some of these are more focused teens and adults, but I'm sure can be improvised as well. Okay. So the 3 things exercise is a grounding technique meant to help the patient stay in the present moment by by using their senses to observe what's around them. And so the way that I do the 3 things exercise is I ask the patient to tell me 3 things that they are seeing currently in the room, 3 things that they hear, and 3 things that they feel touching their body. After that, I then ask them to notice the 3 things they see, hear, and feel all at the same time. And usually this whole thing starts with, 5 deep breaths. We'll do the 3 things. We'll close with 3 to 5 deep breaths. Usually helps keep patients in that present moment or help bring them back if they were starting to dissociate. The second technique that I wanted to talk about is square breathing. And so this is the idea of like thinking of your breath as a square, and having the person inhale for 4 counts, hold for 4 counts, exhale for 4 counts, rest for 4 counts, inhale again for 4 counts. Sometimes it can seem like the 4 counts is a bit long. If patients need to start with 3, that may be a nice way to kind of introduce this. Any questions on square breathing? So with mindful attention, this is a strategy where you could use any sort of object. Kind of one of the ones, and I was thinking of the kids a little bit here, but I think it could even work with adults, is an object like Play-Doh, or a stress ball, bouncy ball, something that they can kind of physically hold in their hand. This is often taught with food, although that can be sometimes difficult, knowing people's food allergies and preferences. It's often done with M&Ms or raisins. But let's work through it with just Play-Doh. So if you're doing the mindful attention exercise with Play-Doh, you're going to kind of walk your patient through all 5 of their senses pretty slowly to get them to, again, observe this object in front of them. So they're standing here, and my plan was to bring Play-Doh, but I didn't manage to remember that today, is to observe it slowly and using, like I said, all 5 of those senses. Or 4 senses. If we're using Play-Doh, we're not really asking them to taste it. So let's talk about Play-Doh. So first, I would hand the Play-Doh to the patient in the container. I'd have them look at it, and I'd ask them some questions about what they're seeing. Sight is kind of the easiest one to start with, right? What's the color? What's the texture? What's its shape right now? What's its size? And then I might slowly have them kind of poke at it in the container. Again, how does it feel? Now we're getting into touch. How does it feel? Does it make a sound? And then maybe even, does it have a smell? Play-Doh has a very distinct smell. Then have them take it out of the container, hold it in their hand. Has the texture changed? Does it feel any different than just poking it in the container? How does it feel when they squish it? How does it smell? Are they having any emotions surfacing as they do this exercise with the Play-Doh? Then to keep working on touch and smell, I'd have them mold it or kind of squish it in their hands as well. The food goes the same way. It's a very slowed down process. You would hold the M&M in your hand, do the whole sight, hearing, touch, and then slowly put it in your mouth when it's in their mouth. And then leave it on their tongue, go through it again. What does it smell like? What any sounds, any taste, sensations, how does it feel? And then chew it up and do that again. So the idea here is that by having an object and making them describe it in more detail than they've probably ever looked at Play-Doh or an M&M, helps them to come back to that present moment. It lets them put those anxieties about the future or thoughts about the past aside and lets them focus on the here and now. Questions on these? Absolutely. All right. Are these techniques that everybody already uses? Amanda, any thoughts on kids?
So yeah, I use, well, not Play-Doh, so I use like the squishy balls that have things in them. And so sometimes I'll have them close their eyes and feel the squishy ball and kind of describe what it is. I also have one of those, I don't know what it's called, but it's those balls that expand and then go back in, right? And so we do that with breathing. In the moment when they're starting to have a really difficult time, we have them just be really mindful of their breathing and do it with the ball. And a lot of the times it's like they're all over the place, and then they get into rhythm and they go in and out with the ball and their breathing. One of the other mindful techniques that I use with kids too, especially my trauma kids who can get easily stimulated and overwhelmed in a session if it goes wrong, and they're very distressed. We need to come back into the here and now. Many of the times we're talking about really difficult pieces, and we need them to focus on the here and now. We do, we have races with peacock feathers. So if you have not tried this, you totally should, but you can balance a peacock feather on the palm of your hand. And that's what we do. We see who can balance it the longest. And that is probably my go-to. It engages kids right away. And it brings them back into the here and now. And so it's really helpful. But yeah, that's what I use for kids.
Awesome. I really like that squishy ball one. I was thinking they often talk about either putting a tissue box on kids' bellies or a lovey on their bellies to help them go up and down, but I know that one can be hard for smaller kids, so that this one sounds wonderful to keep. Anybody else?
Yeah, we do the balloon breathing too, or feathers. So like when we're doing the breathing and teaching the breathing, I like the mad dragon. Kids love to be dragons, and so and like especially when they're angry, that's really helpful for them. But we do the balloons too, where they blow all of their anger into this balloon, and then they pop it afterwards. So a lot of the times you'll hear popping coming from my office. But feathers as well. So if you go up the side of one feather and down the other, it helps them focus on that and their breathing as well. And so it helps them regain there.
I like that. Thank you, Amanda. Anyone else have any grounding techniques they find really helpful and effective? Okay. So hopefully those are a few kind of simple strategies that you can use when your patient is in distress. I know we like patients to kind of come back to their baseline before they leave a session, and sometimes that can be really difficult. And these are just some strategies to help do that. The other thing I wanted to talk about today, because it came up in Dr. Selby Nelson's comments on things that were important to talk about, and that was kind of crisis situations and how do we handle these. So these grounding techniques are good with patients, particularly ones that you've worked with and you know, and you're kind of helping bring them back to the present moment or keep them in the present moment. But what do you do in a situation where it's a person you don't know? Things that come to my mind are, I worked in an emergency department for a while, and you know, patients are coming in and out, some are in distress. You know, how do you help de-escalate those kinds of situations? And I don't know that some of these strategies would work as the first thing to do when you encounter that situation. But I thought it would be something interesting to talk through. Maybe people have some case examples of things where it went right and it also went wrong. And maybe we can talk through what other strategies could be used in similar situations. So in general, in crisis situations, I find that I lean more towards motivational interviewing skills. I think that they can be the most helpful. And using this kind of spirit of MI, as they talk about, is that we want people to take ownership, we want them to be self-efficacious, and we want to assume that they have competency in kind of making decisions and talking through their medical care. Not always the case, but that's kind of an assumption of MI. And so some of the important strategies that MI uses that I think are helpful in these crisis situations. I think reflective listening is the most important strategy that can be used in these situations. And along with reflective listening, so reflective listening meaning you're letting them talk, hear them out, and then reflect back pieces of what they're saying to either clarify or just help them continue the conversation. With that, it's important sometimes to do periodic summaries, can help slow them down. If they hear you repeat what they've said. I was just reading Dr. Selby Nelson's comment in our chat about, calming, de-escalating patients in distress that are angry, upset, or aggressive for various reasons. And again, I'm focusing this more towards adults because that's in general my area. I think it can also work with teens. Maybe Amanda or Lauren can help us a little bit with kids. But to me, again, we're going to do that reflective listening and then summarizing for them. And it can be really helpful if they've told this whole story and then you tell them back in a couple of sentences kind of everything that they talked about. Lets them know that you were listening. And then MI likes to use affirmations and open questions. And that can be somewhat helpful in these situations. But the first two are the ones that I think are really important. What I have found many times is that these frustrations tend to come from feeling as though people are not listening to them. And so sometimes we have to be those people that just let them talk without interrupting. Let them say what they need to say, and then help them to summarize their concerns. And once they've kind of gotten that all off their chest, sometimes they'll be able to listen a little bit longer. And then we can ask them questions such as, what do you want to happen here? What do you hope this outcome is? how do you think we best move forward? And so it kind of comes back to that spirit of MI, right? Let them take ownership of their current situation. Let them feel like they are a part of it. And let them feel like they have authority, right? Like they are the expert in their own situation. And sometimes when you get to emergency departments, or even I'm thinking of the front desk and somebody acting out, it's getting really complicated. People are looking, everyone's getting really nervous. And so we sometimes have to be that person that remains calm, uses kind of deep breaths ourselves, and then I find letting them kind of tell their story. And so I have my next slide, I think, just ask for case examples or questions. I'll give you one example that I have. I will preface it with, again, I mentioned at the beginning that I am a clinical forensic psychologist. So my primary job is that I do forensic evaluations for the courts, meaning somebody with a mental illness commits a crime, and the court wants to know if they're ready to go to trial or not based on their mental illness. And so fairly recently, I had an individual actually came to Chestnut Ridge to see me in person. Jail brought them, 2 officers, and this individual. I had known he was pretty combative with the judge, but he had been pretty good with his attorney recently. The officer warned me that he was pretty combative and that this might be a difficult interview. We sit down, of course, trying to keep 6 feet apart in a big library room. And this individual just starts yelling, he's cursing, he's very delusional. So he's talking about the TV and thinks there's a camera watching him, and he's kind of going off, and I see the officer behind him putting on gloves, which to me means that officer is going to try to take him down. They may have to sedate him. They're going to put him back in the van that drives an hour and a half back to the jail, and I'm not going to get any of the information that I need. And so I kind of gave the officer a look to say, like, give me just a minute with him. And I asked the individual, I basically let the individual talk. He was yelling, he was cursing, he was threatening, but none of it was directed towards me. And so I let him talk. I let him talk for probably 20 minutes. And he kind of slowed down, and I finally was able to say, do you think we could take a deep breath together? And he took a deep breath, and he goes, okay, I'm good. And there, for a little bit of time, there was no more yelling, there was no more cursing. And he kind of calmed himself down, and he said, nobody will listen. I'm trying to tell him, and of course, nobody was listening because it was a completely delusional story about why he got arrested, and it didn't make any sense to anybody. But that was why he was frustrated. And once you could just let him have his say, he calmed down, and he participated in part of an interview until he got upset again, and we discontinued. So it's not the perfect solution, but I think it's really helpful for us to remember that sometimes they just need to feel like they're heard, and they're not getting that from whoever else is around them. And then sometimes it doesn't work. I was telling some of the sharp people before we got on that I am not always successful in these strategies. I also interviewed an individual a few weeks ago who was at Sharp Hospital, and he became very upset with me in the interview, and he began self-harming himself, hitting himself in the head until he was bleeding. And of course, I'm across video from him, and so I'm trying to talk him down, and nothing worked to calm him down. I finally said, would you like to discontinue this interview? And he said yes, and walked out of the room. So again, it's not the perfect strategy, but I think it can be really helpful. Anyone have any thoughts?
I have a question about some of the grounding techniques. Sure. When you go to introduce those, now our occurrences wouldn't be in therapy, so they would be somewhat unfamiliar. How would you go about transitioning that, or what kind of statement would you make to try to get them on board with that?
I think it depends. That's a good question. I think it depends on the strategy. One thought is I might just ask their permission. Could we try something that might help you feel a little calmer, that might help you focus right here and now? I might talk about, anxiety is often when we're worrying about the future. We've got trauma and depression that's kind of worrying or thinking about that past. And it's really helpful if we just can get ourselves into the present moment, can help us feel a little better right here and right now. And that's what I might use to kind of start it off. And then usually once they try it, if they're willing to engage in it, people find it pretty helpful, especially the 3 things. That's kind of my go-to. I don't know if Amanda, Derica, what is the genesis? What's your population age range?
Well, all ages really in any population. So we have emergency shelters where kids live on our campus, but we also have a foster care and adoption services program. We have a mobile crisis unit, and we have Safe at Home, which is a wraparound program. So we have kids on our campus, and we serve children and families in their homes. So all of our staff are, trained in de-escalation and crisis, but, there's always something different works for everyone. So this is really great information that we can use in all of our programs, actually.
Yeah, and I'm sure, I imagine that it matters somewhat the age of the person and the developmental level of the person. Amanda's strategies seem like awesome for the younger kids, but then you start getting into the teenagers. I think that some of these can work. The 3 things exercise I actually learned while working in a juvenile prison. And it with girls who were self-harming, and that was a strategy to kind of help in that crisis moment, to de-escalate, and they found helpful. So
great, thank you, I appreciate it.
All right, so who has questions, case examples, thoughts on de-escalation? If not, I'll have Amanda talk through maybe how to de-escalate a kid more than letting them vent.
Thank you so much, Dr. Lillard. That was such a wonderful presentation, so helpful. And I'll be sure to include this PowerPoint in the recap email as well. But yeah, certainly anyone with any case examples they'd like to discuss, or even questions or comments about the didactic, please feel free to unmute or chat in.
I'm going to stop sharing because I think that'll open up the dialogue a little bit more.
Thank you.
I've had success in the past when working with people with trauma of integrating in some of those skills when they're just starting in sessions with me as well. So teaching them those grounding skills, and we integrate it into their sessions in times where we know it could be harder for them to handle some of those situations. So we just automatically start talking about, let's build these in so we can get to these things. Obviously, it's not moments of crisis where we're using them typically, but I found success in that. And very much like Dr. Lillard was saying, the reflective listening and making sure you're understanding and asking the person if you're understanding what they're trying to express to you, or give them the opportunity to try again so that you can understand them. I find that to be very helpful at points too. Of course, it depends on the person. It's not always successful either.
Yes, I think that's wonderful, Cherry, to think about. If you built that in the beginning, then when crisis arises, they know what you mean when you say, let's do the 3 things. I have got a patient now that I say, okay, we're going to do the 3 things exercise. Would that help you? And she's like, yes, let's do it. And so, yeah, preemptively getting them those skills before it gets tough.
And I like the name 3 things exercise. I know you were saying
boring.
Yes, but I got to say I love it.
You see a lot of people talk about 5, 4, 3, 2, 1, 5 things you see, 5 things you hear. But what kind of smells might you smell in the office? I find that one difficult. And there's usually not things to taste. And so I feel like in the office in the moment, I don't even bring those up because they're more difficult senses to use.
Elizabeth, was there? Did you raise your hand? Yeah.
Yeah, I think that I have anxiety, and I'm very open. I have anxiety and depression. Been battling it since I've been like 13, and just started trying medicine because I'm very holistic. But this past year has pushed me to be open to that. But yes, I will just to, if you don't mind me speaking, the 3 things have always helped me. And the smell thing, I had somebody one time that would have different types of calming scents and the essential oils kind of thing, just because they think that, they know I'm like a little bit holistic. So honestly, that helped me a lot. I don't know if that helps you guys, but they had like a couple different kinds for just calming scents. I don't even really like lavender. They had a different types. I didn't even know what they were. But honestly, that has been very beneficial to me when I'm trying to calm down when I'm feeling very anxious in a situation. So this is really informative.
Thanks for sharing, Elizabeth. All right, let's hear some. Anyone else have a case example? Maybe it didn't go well.
Or any comments or thoughts about the presentation? Doesn't have to be any full-on cases or anything, for sure.
I actually just want to put a plug in for how much I love motivational interviewing and how helpful it really is. Although, Colleen, I have to really praise you, because one of the things I have said with MI is that it's very challenging, I think, to use MI with a patient that's psychotic or intoxicated, where their reality testing is off. So I learned a lot today about that in the context of notable psychosis, which I have not personally had a lot of success with. So it was really impressive to hear you use that and have it work in that setting. But I think you're right. I think people with intense emotions always respond well to feeling validated and listening to, which is really the hallmark of MI. And I just really want to echo that. But also major kudos to you for using it in psychosis, because I have not had, I'm not sure I've tried it that much, but I think that's very impressive.
I will say at another point during the interview, he threatened to bash my head on the table. So I don't know if I was totally successful, but it worked for getting a little bit of information gathered. I should warn you, forensics is just an odd world.
Thank you all so much. Any other comments, questions, or thoughts you'd like to share with the group? And I always want to emphasize too that it's a safe space. Like, you know, we're all here to be supportive and everything. So, Dr. Lillard, do you ever incorporate some type of guided meditation? I know that's kind of a big thing nowadays, but I wasn't sure if there was something on that you had heard of.
Yeah, I think guided meditation, guided imagery is very helpful. I kind of think of it like Charity was talking about. Those are some of those skills let's build in kind of in the beginning. And then maybe could be useful in that crisis. I think sometimes people's emotions are a little high. It's a little hard to get them to kind of go to that place that makes them calm, and let's talk through whatever scene they enjoy. Or I could talk through maybe a beach scene for them. But again, a little hard to do if you don't know them well, if that isn't necessarily their go-to. I think it's sometimes easier just to kind of bring them back into that present moment. And then maybe once they're calm, you could ask, you know, what other coping strategies do you find really helpful? What could we do? Could we practice that guided imagery and meditation?
Thank you. And Amanda or Dr. Swagger, was there anything else you wanted to add as well?
I think, you know, just like we talked about, I think managing the stress with little ones can be different. It can be, well, I don't want to say easier, because sometimes it's not easier. Sometimes it's a little more difficult. But I think it's to the core addressing some of the same issues, right? And so with 0 to 3, you're addressing still those big emotions. And so, like Dr. Lillard said, you really have to look at the development of where that child is or where that individual is and meet that need. 0 to 3 with those big emotions. I mean, you're going to have a parent come in and support them and be there to help regulate those emotions. That's necessary. But then from 3 to 5, you're ignoring a little bit more to allow them to self-regulate on their own without all of that support, depending on where they are developmentally. But helping parents manage that in the moment is some of the most effective work that you can do. And so, parents are always embarrassed when they come in and their child's already tantruming, but it's the best time. And so that's what makes telehealth kind of nice, because we see some of those live emotions too. In crisis situations, same thing. From crisis comes change. And so managing some of those emotions, and in the moment, it can be very stressful. But, with young kids, you're doing the same thing. You're acknowledging the emotion. So a lot of the times with little ones, you're identifying it because they have a hard time identifying it on their own. And then ignoring and distracting and helping parents learn when to come back to that, because many of the times parents, our emotions are heightened with the child, and so you're almost having to help calm the distress from two individuals, the child and the parent. But if you go through the parent, then you're only helping one. And so once the parent kind of calms down, you can help them meet that child in the middle. But yeah.
That's awesome, thank you. And that balancing the peacock feather was really interesting. You taught me. So I'm gonna go out there looking for a peacock feather now.
Yep, Hobby Lobby has tons of them. Michael's has tons of them. They're great, and actually, a lot of my patients have went out and bought peacock feathers on their own because they love doing it so much. It really is a go-to, especially for my trauma kids.
That's great, thank you. Any other comments, thoughts, questions? Feel free to chat in as well. How has everyone's experience been since COVID and like telehealth aspect of things? I know there's some new faces here. If you wanted to share some of your personal experiences, that would be great. Only if you're comfortable doing so, of course. Well, thank you so much, Dr. Willard. This was an awesome presentation, and like I said before, I'll make sure they're in the recap email and everything, so all of you should be able to access it after the fact as well. So if there are no further comments or questions, as always, feel free to email me after the fact, and I'll make sure to have them addressed and everything. So thank you all so much for joining today. The one announcement that I do have is that our next session will be on February 3rd. And Amanda Newhouse is going to be discussing coping with COVID and kids. So keep an eye out for that reminder email, and we'll see you all next time. Thank you again, Dr. Willard, and thank you all so much. Bye.
It's nice to see everyone.